You know, usually when we think about removing a wall in a house, the very first question literally anyone asks is, wait, is that load-bearing?
Right, of course.
Because you wouldn't just, like, swing a sledgehammer and knock out a pillar in your living room without knowing exactly what is holding up the second floor.
No, that would be a disaster.
Exactly. But when it comes to the human body, we don't always think in those architectural terms, do we? We treat organs like they're just individual pieces of furniture.
Yeah, that is a very common misconception, actually. We tend to view our organs in complete isolation from one another.
Like if a chair is broken, you just take it out of the room and you expect the room to stay exactly the same.
Precisely. The standard medical approach for a long time has just been, an organ develops a disease, you surgically remove that organ, and the problem is neatly solved.
But then you look at the female pelvis, and suddenly that logic completely falls apart.
It really does.
So, welcome to today's deep dive. We have a massive stack of sources today for you. We are talking dense surgical journals, anatomical reviews, and patient decision aids from major health bodies.
Like the UK's National Institute for Health and Care Excellence.
Right, NEZ.
Right.
As well as the Royal College of Obstetricians and Gynecologists. And we are taking all this complex literature to dig into one highly specific, incredibly pivotal question. Can a hysterectomy change vaginal support?
It is a structural mystery that affects millions of people globally, yet it rarely gets discussed with the architectural respect it deserves.
I am going to give you the big reveal right out of the gate. Yes, it absolutely can.
Undeniably.
Removing the uterus isn't just about removing a reproductive organ. It is about fundamentally altering an intricate load-bearing support system. But I'll be honest, looking at these anatomical diagrams, it's incredibly complex.
It's a lot to take in.
It really is. So, to really understand how a hysterectomy changes the support, we first have to understand the underlying architecture of the female pelvis.
Well, if we start at the absolute foundation, you have the bony pelvis.
Okay.
This is made up of the ilium, the ischium, and the pubis bones, which basically fuse together to form this rigid, protective ring.
Like a basin.
Right. And the bottom of this bony ring is lined by a broad, dynamic sheet of muscle called the pelvic diaphragm.
Okay, I'm with you.
And within this relatively small space, you have three distinct compartments. The bladder sits in the front, the vagina and uterus are right in the middle, and the rectum is in the back.
Okay, wait, I have to stop you there because I'm a bit confused by how this actually works with gravity. I mean, we walk upright?
We do.
So are these organs just like rattling around in there, sitting at the bottom of this bony bowl? If I cough or lift a heavy box, why aren't my organs just dropping straight down onto that muscle floor?
Well, they don't drop because they are actively suspended.
Suspended.
Yeah. To understand how they defy gravity and pressure, we rely heavily on the work of a pioneering researcher named Delancey. He mapped out three critical levels of support.
Okay, level 1, what's that?
Level 1 is the superior suspension. Think of the cardinal and uterosacral ligaments. These are thick bands of tissue connecting the top of the vagina and the cervix all the way back to the sacrum.
The bone at the base of your spine, right?
Exactly. That holds everything up from above. Then you have level 2, which provides lateral support, anchoring the sides of the vagina horizontally to the pelvic floor muscles.
So pulling it tight side to side.
Right. And finally, level 3 is the distal fusion, where the lower part of the vagina attaches to the surrounding structures near the actual opening of the body.
Wait, so it's not a bowl at all, it's a web.
It is a continuous living web, and the material making up that web is called the endopelvic fascia.
Fascia. Okay, I've heard that term.
Yeah, it's this network of connective tissue and smooth muscle. It acts as a physical, fibrous matrix that literally envelops all these pelvic organs.
Like packing peanuts, but made of living tissue.
Sort of, yeah. The fascia is the glue maintaining the exact anatomical relationships and distances between the bladder, the uterus, the vagina, and the rectum.
Okay, let's unpack this for a second. If we think of the pelvic floor like a suspension bridge, those level 1 ligaments tying back to the spine, they are the tall anchoring masts.
That's a great way to look at it.
And the pelvic floor muscles, along with that fascia, are the lateral wires holding all the tension across the roadway.
That visual captures the mechanics perfectly. The sacrum and the perineal body act as the firm anchoring points of the bridge at either end.
So these organs aren't just resting. They are actively tensioned against each other to withstand intra-abdominal pressure.
Yes. In the literature, this mechanism is actually called the hammock hypothesis.
The hammock hypothesis.
Right. The muscles and the endopelvic fascia act together as a dynamic hammock. When the pressure inside your abdomen suddenly spikes, like when you sneeze or jump or lift something heavy, this hammock reacts.
It tightens up.
Exactly. It actively compresses the urethra shut so you don't leak urine, and it provides firm backing to support the bladder, the vagina, and the rectum.
Wow.
It is a real-time, dynamic coordination of constriction, suspension, and structural geometry.
Wait, but if everything relies on this tensioned hammock, what happens when a surgeon literally cuts the center anchor out of it?
And that is the core issue.
Because this system relies on interconnected tension. So removing a central structure, like the uterus, that must force the entire suspension bridge to bear weight differently.
It drastically alters the mechanical load. When a surgeon performs a hysterectomy, they are removing the uterus, an organ that sits right at the apex of this delicate support system.
Right in the middle of the bridge.
Exactly. And to take it out, they have to sever those level 1 support structures we talked about.
The uterosacral and cardinal ligaments.
Right. And the data on what happens next is, well, it's sobering. Over 10% of women who have a hysterectomy experience varying degrees of prolapse symptoms later on.
10% is a lot.
It is, but in some of the long-term observational studies we reviewed, the incidence of post-hysterectomy prolapse reaches as high as 43%.
43%. Wait, really? That is a massive number.
It's staggering.
That means almost half of the people undergoing this very, very common surgery might face structural collapse down the line.
The physiology behind that number comes down to those severed ligaments. If they aren't properly re-anchored during the operation, those remaining structural connective tissues pull away or weaken over time.
Because they're just, what, hanging there?
Essentially, yes. This leaves the very top of the vagina, which we call the vaginal vault, completely unsupported from above. Without that upward suspension pulling it toward the spine, the vault can begin to sag downwards.
We're talking about post-hysterectomy vaginal vault prolapse, or PHVP, right?
That's the clinical term, yes.
Looking at the clinical descriptions in these papers, it sounds incredibly severe. Like, in the worst cases, the vaginal vault can literally collapse into itself.
Yes, effectively turning a vagina inside out, which the medical texts call eversion.
That sounds terrifying.
It's a profound structural failure. But what's fascinating here is that delving into the risk factors reveals an important nuance. The single biggest predictor of post-hysterectomy vault prolapse is actually a pre-existing pelvic floor defect.
So if things were already a bit loose.
Exactly. If a patient's original hysterectomy was performed as a treatment for pelvic organ prolapse, meaning things were already falling, their risk of developing vault prolapse later is 5.5 times higher.
Wow. Compared to someone who had a hysterectomy for, like, fibroids or heavy bleeding,
Right.
it's like removing the center pole of a heavy canvas tent.
Mm-hmm.
If the side ropes were already fraying and you decide to just pull out that main structural beam, that heavy canvas is inevitably going to collapse.
That's exactly it. The compromised endopelvic fascia and the weakened levator muscles were already struggling to hold the load.
Yeah.
Removing the uterus just accelerates the failure of whatever support system was left.
And this physical collapse, I mean, it isn't just an anatomical curiosity for medical textbooks. When you read the patient decision aids from NICE, you realize this drastically alters a person's daily life.
Immensely.
It brings on an entire cascade of unexpected and honestly devastating physical symptoms.
Because the pelvic organs share this intimate fascial connection, a failure in one compartment rarely stays isolated. The surrounding architecture gets dragged down too.
Right, the symptoms women report are intense. They describe a heavy, dragging sensation in the pelvis as if things are physically falling out of them.
Yes, a very common complaint.
Or they report a physical bulge that they might actually be able to see in a mirror or feel when washing. And there's often this severe, constant lower backache.
Which makes perfect sense anatomically.
Because of what you said about those level 1 ligaments tying back to the sacrum. If the vault is falling, it must be yanking on those ligaments connected to the lower spine.
Exactly. The tension is entirely displaced. And then you see the collateral damage to the adjacent systems.
Like the bladder and bowels.
Right. The bladder sits just in front of the vagina, and the rectum rests just behind it. When the vaginal vault drops, it fundamentally changes the spatial volume of the pelvis.
So they get squished.
Or stretched out of position. Patients suddenly experience urinary frequency, overwhelming urgency, or stress incontinence. Or, on the flip side, the changed angles mean they have severe difficulty completely emptying the bladder or the bowels.
Ooh, I want to talk about one specific detail from the sources that really shocked me. regarding bowel movements.
Ah, splinting.
Yes, splinting. Some women have to apply manual pressure, literally pressing their fingers against the vaginal bulge or the perineum, just to help open their
It's a
bowels.
very distressing symptom.
I cannot imagine the physical and emotional toll of having to manually reposition your own organs just to go to the bathroom. That is an incredible everyday hurdle.
Splinting occurs because the structural wall between the vagina and the rectum has weakened so much. When the patient tries to push to have a bowel movement, the stool doesn't go down and out.
Where does it go?
Instead, it pushes forward into the newly created empty space in the vagina, creating a pouch. The patient has to physically push that pouch back into place to direct the stool correctly.
That is just a profound disruption to basic bodily functions.
It is. And this raises an important question about quality of life, especially because we must also acknowledge how heavily this impacts sexual function.
Absolutely. The decision aids highlight that this structural shift can lead to severe pain, discomfort, or a feeling of obstruction during intercourse.
Because the vaginal canal itself might become foreshortened.
Plus, there is simply overwhelming anxiety for the patient about whether sex is even safe or if it will cause further anatomical damage.
Understandably so. Even routine hygiene and care become complicated. The anatomy shifts so significantly that using a tampon might become physically impossible because it simply won't stay in place.
The entire internal landscape has just changed. So, if I'm understanding this, the organs are playing a high-stakes game of spatial musical chairs. When the vault drops, it's dragging the bladder and bowel into the newly empty space with it.
That's a good analogy. The connective tissues are mechanically pulling the adjacent organs down. There is no rigid wall to stop them anymore.
Knowing this severe domino effect exists, how do surgeons prevent it? I mean, when a surgeon is in there removing the uterus, do they just stitch the top of the vagina closed and hope for the best?
Well, for a long time that was often the case.
Really?
Yes, but modern guidelines are very clear now. A hysterectomy alone will not cure uterovaginal prolapse, and simply closing the tissue is insufficient.
Okay.
The surgeon must actively utilize the leftover supportive structures at the time of the initial surgery to support the vaginal cuff. You have to rebuild the suspension bridge while you are taking out the center pillar.
How do they actually do that? What are they attaching the newly closed vagina to?
They employ specific preventative techniques, the most common being a McCall-Coldoplasty or a uterosacral ligament suspension.
A McCall-Coldoplasty. Okay.
During this procedure, the surgeon takes those level 1 support ligaments, the cardinal and uterosacral ligaments that they just attached from the removed uterus, and physically synfers them directly to the newly closed top of the vagina.
Oh, I see. So they're taking the masts of our suspension bridge and tying them directly to the new roof of the vagina.
Exactly, preserving that upward tension toward the spine. They are recreating the natural anatomy's tension lines as closely as possible.
Does it work?
Very well. If we connect this to the bigger picture, the clinical data strongly validates this proactive approach. Meta-analyses of vaginal uterosacral ligament suspension show an incredibly high success rate, up to 98.3% successful anatomical outcomes when these ligaments are used proactively.
98.3%. That's amazing.
Yeah.
But okay, here's where it gets really interesting to me. I was reading through the RCIG guidelines, and I got a bit confused.
Okay, what about?
If removing the whole uterus causes the collapse because we lose that central anchor, why not just leave the bottom part of the anchor behind?
Keeping the cervix.
Right. The cervix is the lowest part of the uterus, right where these crucial ligaments attach.
Yeah.
Wouldn't a subtotal hysterectomy where a surgeon just removes the top part of the uterus but keeps the cervix prevent this whole vault prolapse issue entirely? It seems like a no-brainer.
It is a very logical assumption, and honestly, it was a subject of intense debate in the gynecological community for years.
So I'm not crazy for thinking that.
Not at all. The theory was exactly as you described: keep the cervix, keep the pelvic floor intact. However, the current Royal College of Obstetricians and Gynecologists guidelines explicitly state that a subtotal hysterectomy is not recommended for the prevention of post-hysterectomy vault prolapse.
But why not? If the ligaments are still attached to the cervix, shouldn't it hold?
Because the evidence shows it simply doesn't work that way in practice. Leaving the cervix does not offer better long-term support than a properly suspended total hysterectomy.
Oh, really?
Yeah, the mechanics of the failure are twofold. First, if the patient's ligaments and endopelvic fascia were already weak, leaving the cervix attached to weak ligaments doesn't magically make them strong.
Oh, that makes sense.
The cervix will eventually prolapse anyway. Second, And perhaps more surprisingly, meta-analyses have shown that a subtotal hysterectomy can actually lead to higher rates of urinary incontinence compared to a total hysterectomy.
Wait, keeping the cervix causes more incontinence. How does that even happen?
Well, when you leave the cervix, you are leaving a physical mass resting right against the bladder and the urethra, but you've altered the tension of the hammock surrounding it.
Okay.
This can disrupt the delicate neurological and anatomical relationship that keeps the urethra properly compressed during physical exertion. You lose the dynamic control.
Wow. So leaving that piece of the load-bearing wall doesn't save the house, and it might actually cause the plumbing to leak because the tension on the pipes is all wrong.
That is a very apt translation of the clinical data. The key to preserving the architecture isn't leaving the cervix. The key is properly reattaching the suspensory ligaments to whatever tissue remains at the apex of the vagina.
But what happens if those preventative measures fail? Or what if a patient had a hysterectomy 20 years ago, before these suspension techniques were standard practice?
That's a very common scenario.
Or if the connective tissues simply weaken over time due to age, the drop in hormones during menopause, or weight gain? That leads us to the repair phase, right? Fixing the foundation after the house has already started to sink.
Exactly. And managing a post-hysterectomy vault prolapse requires a highly individualized approach. We divide the treatment pathways broadly into non-surgical management and surgical repairs.
Let's start with the non-surgical route, because the IMS decision aids put a heavy emphasis on trying these as a first line of defense.
Always.
It starts with lifestyle changes, which makes total sense when we think about the hammock hypothesis. Losing weight directly reduces that constant intra-abdominal pressure pushing down on the hammock. Right. And treating chronic constipation means the patient isn't straining and further stretching those weakened ligaments. Then there's targeted physical therapy.
Pelvic floor physiotherapy is a crucial intervention, but it is not just a matter of telling a patient to do Kegel exercises at home.
No.
No, a specialized physiotherapist will often use biofeedback to help a patient isolate and strengthen the correct muscle groups.
I saw biofeedback mentioned a lot in the literature. What does that actually look like in a clinical setting? How do you get feedback from a pelvic floor muscle?
Well, the physiotherapist inserts a small sensor into the vagina or places electrodes on the skin around the perineum. These sensors are connected to a computer screen.
Oh, wait.
When the patient tries to contract their pelvic floor muscles, the levator ani, they can actually see a visual representation of that contraction on the screen, like a graph spiking upward.
Oh, so they know they're doing it right.
Exactly. Because these muscles are internal and hard to feel, many patients unknowingly clench their abdominals or buttocks instead. Biofeedback provides real-time visual proof that they are purposefully building that specific muscle sling to support the falling organs from below.
That's fascinating. And for immediate physical support, doctors often prescribe vaginal pessaries. From the diagrams, these are medical devices, usually made of flexible silicone or PVC, that are inserted directly into the vagina.
Yes.
They look like rings, or sometimes solid cubes, and they physically prop up the prolapsed tissue, essentially acting as an artificial removable scaffold. But the guidelines mention they are often used in combination with vaginal estrogen creams. Why is the estrogen necessary?
The estrogen is vital, particularly for postmenopausal women. Without estrogen, vaginal tissue becomes very thin, dry, and fragile.
Oh, I see.
The constant friction of a plastic or silicone pessary rubbing against thin tissue can cause painful ulcerations or even bleeding. Localized estrogen cream helps keep the vaginal tissues plump, healthy, and resilient enough to tolerate the device.
Makes perfect sense. But if conservative management fails, or if the prolapse is simply too severe to be held by a pessary, we have to look at surgical repairs.
We do.
And the surgical options vary wildly in their approach and their risks. Let's look at the three main ones highlighted in our sources. First, there's vaginal sacrospinous fixation.
Right. This procedure is performed entirely through the vagina, avoiding any abdominal incisions. The surgeon uses strong stitches to attach the top of the fallen vaginal vault to a very sturdy ligament deep in the pelvis, called the sacrospinous ligament.
If we go back to our house analogy, this sounds like tacking a sagging ceiling directly to a strong sidewall.
That's a good way to picture it.
But the data notes this is a native tissue repair, meaning it uses the patient's own body tissues. The advantage is a quicker recovery, right?
Generally, yes.
But the disadvantage is pretty glaring. Native tissue can fail again. The recurrence rate for vault prolapse with this procedure is between 14% and 30%. Also, some patients experience a sharp temporary pain in their right buttock. Why the buttock?
It comes down to nerve proximity. The sacrospinous ligament sits very close to the pudendal nerve and the sciatic nerve
Oh,
pathways.
the sciatic nerve. Ouch.
Yeah, when the surgeon places stitches into that ligament, it can cause localized inflammation or nerve entrapment that literally radiates pain down into the buttock until the tissue heals.
Okay, so a less invasive option, but with the fairly high recurrence rate and some specific nerve risks. The second option is the abdominal sacrocolpopexy.
Yes.
This can be done via open surgery or keyhole laparoscopy.
Yeah.
Here, instead of using the patient's own tissue, they use a permanent synthetic plastic mesh. They attach one end of the mesh to the vaginal vault and anchor the other end all the way up to the sacrum, that solid bone at the base of the spine.
The mechanical advantage here is profound. You are anchoring directly to bone, and the synthetic mesh doesn't stretch or degrade like natural aging tissue might.
So it lasts longer.
It generally boasts a lower recurrence rate and maintains the natural length of the vaginal canal. However, it introduces the unique and serious risks associated with synthetic mesh.
Right. To use our analogy, this is like running a heavy-duty steel cable straight up to the roof beams. It's incredibly strong. But the FDA and various medical guidelines note that the body doesn't always like foreign materials.
Not at all.
The mesh can cause chronic inflammation, and over time it can actually erode through the vaginal wall or perforate adjacent organs like the bowel or bladder, and fixing that requires multiple, incredibly complex revision surgeries to painstakingly remove the embedded plastic.
It is a highly calculated trade-off between the durability of the repair and the specific, potentially severe risks of implanting a permanent foreign material into a dynamic, moving part of the body.
Which brings us to the third surgical option in the sources, colpoclysis. This is literally the complete closing off of the vaginal canal.
Right.
The surgeon sews the front and back vaginal walls together, effectively pushing the prolapsed organs back up into the pelvis and sealing the face shut permanently.
Colpoclysis has an extremely high success rate for resolving the prolapse. Furthermore, because it doesn't involve deep anchoring or opening the abdomen, it is physically much less demanding to recover from.
So it's easier on the body.
Yes. It is often the preferred choice for elderly patients or those with severe comorbidities who might not survive a long surgery. The trade-off, however, is absolute. It results in the permanent loss of the ability to have penetrative intercourse.
So what does this all mean? Looking at these options, it sounds like choosing a surgery isn't a one-size-fits-all fix. It's a highly personal, incredibly nuanced trade-off between anatomical durability, surgical risk, and the patient's desired lifestyle.
That is the absolute core of modern urogynecology. The paternalistic days of a doctor simply deciding which surgery to perform are gone.
Thank goodness.
It must be a process of shared decision-making. You and your surgeon have to balance your age, your overall health, your desire to maintain sexual activity, and your personal tolerance for risk.
It's a lot to weigh.
It is. And crucially, it requires setting realistic expectations. The data shows that about 3 in 10 women who have an operation for pelvic organ prolapse will eventually need another prolapse surgery later in life.
3 in 10. That stat really grounds this entire discussion. We aren't talking about fixing a broken bone where it sets, heals, and you're done. We're talking about managing a dynamic, living suspension system that undergoes constant wear and tear every single time you cough, laugh, or lift a grocery bag.
Exactly. It demands an ongoing relationship between the patient and their care team to manage these structural changes over a lifetime, adapting the support as the body ages.
Which brings us to the ultimate takeaway for you, the listener, regarding how we view the human body's structural integrity. We started this deep dive with the mission to answer a single question based on all these medical guidelines. Can a hysterectomy change vaginal support?
And the answer is unequivocally yes.
Because the uterus acts as a central node, a vital load-bearing pillar in the pelvic suspension bridge. Its removal forces the surrounding ligaments, muscles, and fascia to take on loads they weren't entirely designed for.
And without careful, proactive surgical compensation at the time of the hysterectomy or complex structural repairs later on, that entire pelvic floor is at a remarkably high risk of collapsing.
Acknowledging this fundamentally changes how we must view gynecological surgery. It is not just organ removal, it is advanced structural engineering.
It really is.
And it leaves you with a final, lingering idea to chew on long after we wrap up here today. If the removal of one single organ, an organ we routinely remove millions of times a year worldwide, can cause a structural collapse that affects everything from your bladder's ability to hold urine to the alignment of your lower spine.
It makes you wonder.
It does. What other organs in our bodies are quietly providing hidden structural scaffolding that we completely take for granted right up until the moment they are gone? What other load-bearing walls are we swinging hammers at without ever looking at the blueprints?
It's a profound thought.
It really is. Thank you so much for joining us on this deep dive. We'll catch you next time.